looks more promising. There we go. Thank you so much. Apologies. Okay, so today what we're going to do is we're going to review the current literature. We'll go over our recent COT study. The most important thing is we want to identify both the patient and the fracture patterns that place these patients at high risk for non-union. I really want to review why it's super important to address these patients nice and early, and we touched on this a couple of days ago. And then we'll talk briefly about some surgical approach tips and tricks as well. So we'll start off here with a 45-year-old female, BMI 30.5, a little elevated, right-hand dominant, and she is a non-smoker. So this is her initial injury films, immobilized here in a sugar tong. So I just want you to think about how you would treat this today, how you maybe treated this a couple of years ago, and how maybe you'll treat it at the end of this talk. So we know that this is a fairly small portion of our overall fractures, up to about 5% are mid-diaphyseal humeral fractures. And traditionally, these have been treated non-operatively with slings, Sarmiento bracing. However, it was coming out in the literature fairly consistently that non-union rates were as high as a third of these patients. But there were some substantial limitations in our literature: small studies, heterogeneous populations, non-randomized, and a lack of patient-reported outcome measures. And so this is where the COTS group set out to conduct this randomized controlled trial over the past 10 years or so, 12 participating sites. It's really important to know who was in this trial. So these were adult patients that had diaphyseal fractures that were amenable to both non-operative and operative treatment. And they had to be enrolled in the study and treated within 21 days. We did not include those that had very proximal fractures or very distal fractures. We also did not include those patients that had polytrauma or, for example, had a neurovascular injury that required intervention. So it's really important to know these are isolated humerus fractures. Our primary outcome was the DASH score, so a real patient-reported outcome measure, and then we had a whole host of other radiographic and clinical outcomes as well. We followed the patients out to 12 months, and so we had good serial data on these patients. Patients were randomized to either surgical fixation, open reduction internal fixation, not humeral nailing, with either a 3.5 or 4.5 plate and screw construct. They were immobilized just for the first 7 to 10 days or so, and then went on to have standardized physiotherapy, early range of motion, and strengthening as tolerated by 6 weeks. If they were randomized to the non-operative group, they were immobilized in a sugar tong for 10 to 14 days, began early range of motion, but strengthening wasn't formalized until about 6 weeks. Functional braces remained on until there was radiographic evidence of healing. So we randomized 178 patients, 168 are included in the analysis that I'll present here, and we did achieve 85% follow-up of these patients at 12 months. This busy table 1 is simply to illustrate that there was no difference in demographics between the two groups. So if we look at our primary outcome here, the DASH score in this forest plot, you can see that early on, the timeframes are on the left, early on we had functional improvement that favored operative intervention with open reduction internal fixation, and this really persisted out to 4 months for the DASH score. If we look at the constant shoulder score, which does have a strength component to that measurement, we can see that this improvement in early function with operative fixation persists out to about 6 months. And so I'll just summarize some of the other findings from this study as briefly as I may. We did have a very low incidence of iatrogenic nerve injury in the surgical group, only 1.2% in this trial, and a low infection rate at 1.2% as well. And so what we can see is that early shoulder strength, range of motion, radiographic alignment were improved with surgical fixation. And importantly, with non-operative patients treated non-operatively, there's a lot of information in this trial that can help with some counseling. So the fracture has a good chance of uniting. However, it will take 4 to 6 months for functional recovery. And there is a 13.1% chance of non-union that would require surgical intervention. That strength and range of motion really can be limited somewhere to 4 to 6 months. And so all of this information means that we have data now to support selecting the appropriate patient that would benefit from surgical intervention. And so we know surgical intervention can provide early functional recovery, more rapid fracture healing. However, we have to take into consideration the patient, functional demands and have a conversation with them so there's some shared decision making. So now moving on to how do we apply this to patients so we avoid the situation that we talked about a couple of days ago with non-union. So there's fairly well-established non-union risk factors in long bone fractures: smoking status, increased age, BMI, and some unstable fracture patterns. So what we wanted to do is really look at those patients that went on to non-union in our trial. So of the 13 non-unions, 11 of them were in the non-operative group, as I mentioned, 13%. When we looked at a regression analysis, the outcome that came out as a significant predictor of non-union was elevated BMI. So those patients with the larger soft tissue envelope, really not very amenable to bracing. That really came out as a risk factor for non-union in this trial. And then I did want to highlight that there were more non-unions in the patients that were former or current smokers. It wasn't statistically significant. We had a pretty low rate of smokers, only about a third of the patients in this trial. Okay, so we now know the patient factors at risk. What about the fracture patterns that are at risk? All of the non-unions in this trial occurred in simple A-type fractures. Those simple transverse mid-diaphyseal fractures, rotationally unstable, had a higher risk of non-union. So now we're able to see the patient in our clinic that has an elevated BMI, a simple fracture pattern, and know that we need to have a little bit more clinical suspicion for an increased risk for non-union. And the reason that this is really important is these patients went on to require surgical intervention because they were symptomatic. All 11 patients with non-unions in the non-operative group had surgical intervention. 7 of them were not bone grafted. 5 of them, at the time, iliac crest bone grafting was used to help augment fixation. And it's important to know that the average time to surgical intervention in this trial was late. It was 18 weeks, and these patients were quite symptomatic. So this is really important because there was poor function in these patients regardless of surgical intervention. So at any time point out to 12 months, these patients did worse from a patient-reported outcome score with DASH as well as constant shoulder score. They never really catch up if we don't intervene early on. So early identification of non-union risk is extremely important. I do want to highlight that the COTS trial did have a fairly low non-union rate compared to probably the other landmark large trial, the FISH trial, which reported a 25% non-union rate. We now know that the risk factors for non-union with non-operative treatment are elevated BMI, simple fracture patterns, and we definitely want to do some counseling around smoking cessation. It's important to recognize this early because these patients don't catch up. They have worse functional outcomes all the way out to 12 months with delayed surgical intervention. Okay, so back to our young lady here, 45, elevated BMI, right-hand dominant, simple fracture pattern. Here she is at 2 weeks, and you can sort of see on the right-hand or left-hand side, I apologize, someone's trying to reduce this. We're not happy with the alignment. Here she is at 6 weeks. We now have a bit of fracture resorption, perhaps even a bit of gapping because of the weight of the arm in this particular body habitus. Here we now are at 4 months. We're seeing callus formation, but this is an unstable fracture, and she's going on to a hypertrophic non-union. This is mobile, and she's symptomatic. So we can see this coming much earlier than when she underwent surgical fixation for stabilization of this non-union. So early recognition is important. Last topic here, and we'll have some discussion around this, I'm sure, but surgical approach. So for myself, at the moment, anterolateral is generally my preferred approach. However, the caveat being my number one indication for surgical fixation is usually a polytraumatized patient at this time. So Dr. McKee was talking about delta pectoral approach. This is an extension distally. Some advantages are the polytraumatized patient. You can fix the humeral diaphyseal fracture with multiple other injuries, or say a patient that's on spinal precautions. It's extensile, so that has some advantages as well. Brachialis, I often find that actually, unfortunately, by nature of the acute fracture, this is disrupted, so that can be your opportunity to decide whether you split or mobilize it out of the way gently. Be very careful with Hohmann's retractors in the distal third, recognizing the radial nerve pathway. And then, if needed, a small anterior release of the deltoid can give you a little bit more real estate for your surgical fixation. And so traditionally, and in our COT study, patients receive single 3.5 or 4.5 plates. I will say that there is some emerging evidence to support some potential advantages to the use of dual plating. So things like perhaps a less extensive dissection can act as a provisional fixation tool, reduction aid. You get some increased screw density, so a shorter construct, and then some rotational control, which we know is really important, these diaphyseal simple fractures. So just some fun data that is hot off the press, currently under review. We did a biomechanical study looking at a number of different dual small fragment and midi fragment constructs. We really wanted to compare this to a 3.5 single plate construct. All of our dual plate constructs are on the blue, highlighted in blue, and the single plate construct is in red. And across compressive stiffness, medial bending stiffness, and torsion, really important, we did see significantly more stiffness or stability with dual plate constructs, not surprisingly. There was really no difference between the different dual plating constructs. So it's just an adjunct that you may want to consider. Again, the goal is to get these patients up and moving and immediately weight bearing. So hopefully we've achieved our objectives today. Early functional recovery with open reduction internal fixation to help counsel your patients. Elevated BMI and simple fracture patterns are high risk for non-union. Poor outcomes if we delay intervention for that fracture and patient that has those risk factors. And lastly, anterolateral for most, posterior approach for more distal fractures, and consider dual plating as an adjunct. And I look forward to talking about that further. Thank you.